Hi, my name is Shelby Day. I'm a doctoral student at Lee University. I am sharing with you the results of my project entitled The Effects of Formal Sex Education Received Before 18 Years Old and Religiosity on the Young Adults Seeking of Sexual Health Services. Out of respect for your time, I will be moving through much of the background of this project very quickly. If you have any further questions or comments, please feel free to reach out via my contact information at the end of the presentation. According to the CDC, roughly 20% of the U.S. population had an STI in 2018. That year, STIs cost the U.S. healthcare system almost $16 billion. Still, it is likely that many infections go undetected and unreported. What is most significant about such a high percentage is, perhaps, the population affected. Almost half, 45.5% of new STI diagnoses made in 2018 were of those 15 to 24 years old, indicating a significant disparity for the adolescent and young adult populations. Sexually active adolescents 15 to 19 years old and young adults 20 to 24 years old are at higher risk for getting STIs for behavioral, biological, and cultural reasons. Higher STI rates may also be attributed to a lack of access to sexual health services, lack of education as to when to seek sexual health services, concerns about confidentiality, embarrassment regarding exams and testing, and religious and cultural influences. Here are some background terms that you are likely already familiar with. Of note, we will be defining religiosity as the degree to which the individual believes in and honors the chosen God and practices the applicable teaching and participates in the relevant activities. Little is known about how religiosity and formal sex education impact the seeking of sexual health services. The STI disparity documented for adolescents and young adults further necessitates research focusing on the care-seeking behaviors of this population. We endeavored to answer the question, for young adults aged 18 to 25 in the United States, how does formal sex education received before 18 years old and religiosity affect the young adult seeking of sexual health services? According to the literature, less than half of high school students receive instruction on all CDC essential topics for sex education. Additionally, religiosity has positive and negative effects on sexual activity. Sexual health educational interventions targeting young adults are not ubiquitous, and adolescents and young adults are not well targeted for sexual health services. A conceptual framework was developed for this project. This shows the interacting concepts of sex education, religiosity, risky sexual behavior, and seeking sexual health services. And the theory of care-seeking behavior was used as the theoretical framework for this project. We utilized a voluntary response sample targeting young adults 18 to 25 years old residing in the United States and using social media. We developed a survey which was entered into SurveyMonkey and then was distributed via social media platforms. Demographic information was collected on sex, age, personal religious affiliation, and family religious affiliation. Additionally, the respondent was asked questions related to sex education received and in what setting. An assessment of sex education was done by asking questions regarding the individual's recall of formal sex education received before they were 18 years old. This tool was developed for this study and assessed the participants' recall of receiving formal sex education on the CDC essential topics for sexual health education received before 18. Scoring utilized a 5-point Likert scale which generated an overall score. The Adherence to Religious Doctrine Concerning Sexual Behavior survey was used to assess the influence of religiosity on sexual behavior. The tool is broken down into two sections, reasons to follow and reasons to break. An established risk score tool was used for this survey. The assessment generated a score which interpreted the individual's risk for STIs. History of seeking sexual health services was measured by the participants' reported history of using select services. Again, the aim of this project was to identify the influence of religiosity and formal sex education received before 18 years old on the young adults seeking of sexual health services. According to the theory of care-seeking behavior, interacting concepts like religion and education influence the individual's decision to seek or not to seek care. The goal being, in understanding these relationships, health promotion initiatives can be tailored to increase the young adults' use of sexual health services. So in completing this project, we had 1,136 surveys collected, 965 remained after cleaning for inclusion criteria, and complete survey sections were used in data analysis. Most participants reported some personal or familial religious affiliation. The vast majority were sexually active and reported receiving some formal sex education before they were 18 years old. Most did not specify their religious affiliation, but of those who did, the majority reported being Christian or Catholic. Predictors of recall of sex education. The more recently formal sex education was received in a required course, the higher the RSE score. It may be that these courses offered later in adolescence included more of the surveyed topics, or that it was easier to recall the more recently taught topics. Participants reporting personal or familial religious affiliation scored slightly higher in RSE than those who did not. Most participants received their formal sex education from the public school system sometime between the ages of 14 and 18. RSE scores were highest among those reporting a receipt of education between the ages of 14 and 18. Comparably, RSE scores were highest among participants reporting receipt of formal sex education at youth group and homeschool. It is possible that the formal sex education being taught in these groups may be beneficial in increasing the understanding of sex education topics. Perhaps in these more intimate settings, youth group and homeschool participants received more individualized sex education, thus increasing their RSE scores. Predictors of STI risk. The difference in RSE scores in those reporting being sexually active versus denying sexual activity suggested that receiving formal sex education before 18 years old may help delay initiation of sexual activity, which is consistent with existing research. It is thus presumable that sex education involving more topics significantly decreases the young adult's risk for STIs and delays initiation of sex when accounting for religiosity. Young adults who reported higher reasons to follow scores were at a higher risk for STIs, but the opposite was found among participants reporting personal or familial religious affiliation. Previous research has shown positive as well as negative relationships between religiosity and sexual risk behaviors. To further support the protective effects of religiosity, participants scoring high in reasons to break were at a higher risk for STIs. Although RSE scores were highest among participants who received their sex education from homeschool and youth group settings, these groups had some of the highest STI risk scores. This may indicate that although recall scores were higher and educational interventions may have included more topics, the quality of the education was lacking in efficacy to reduce STI risk. This is compared to public school group who saw the lowest STI risk scores. Predictors of seeking sexual health services. Young adults reporting the highest reasons to follow and reasons to break scores were more likely to seek sexual health services like STI testing. It was hypothesized that individuals reporting high religiosity would be less likely to seek sexual health services due to cultural influences, but these calculations suggest otherwise. Earlier initiation of sex education was associated with higher SSHS scores, which is supported by current recommendations. This pattern may indicate the normalization of sexual health via beginning conversations during the 5 to 10-year-old age range. Formal sex education involving more topics makes the young adult more likely to seek sexual health services. This relationship further advocates for the use of CSE over AOE when choosing sex education curriculums for adolescents. Federally funded programs tend to stress the avoidance of STIs, but not health promotion behaviors. It may be that programs that are not regulated by federal funding do more to stress sexual health services. It is important to note that these findings may not be generalizable to the entire U.S. population, considering the difference in population demographics. Some populations were overrepresented and others were underrepresented. Considering the potential effects of socioeconomic status on the studied variables, this could be significant. Important limitations include the use of a voluntary response sample and potential reporting bias from self-report measures. There were more complete responses in the recall of sex education section than those reporting receipt of formal sex education. This implies that the RSE scores and findings may not be specific to formal sex education. Additionally, relationship status was not evaluated by the survey. Based on this STI risk assessment, a recently married monogamous individual with no STI history using a birth control method other than a condom would score a 5 compared to the mean score of 5.47. Without consideration for relationship status, STI risk scores may have been skewed to appear higher than they were in reality. 4 items in the SSHS section were more specific to the female sex, and this bias may have skewed male SSHS scores. Lastly, this survey was posted on the principal investigator's personal social media accounts and multiple primarily academic pages. It is possible that if a participant knew the principal investigator personally, they may have answered differently based on their emotions towards the topic. It is also possible that the socioeconomic status and educational backgrounds of participants may have differed from the general population. Socioeconomic status and education were not surveyed in this project and may have been skewed when considering the nature of the pages that the survey link was posted to. The goal of this project was to identify factors influencing the young adults seeking of sexual health services, specifically education and religiosity. This knowledge can be used to assist in the identification and targeting of interventions aimed at decreasing young adults' STI and unplanned pregnancy rates. These include current formal sex education programs for adolescents and young adults, as topics being taught to adolescents may have lasting effects into young adulthood. Existing knowledge is sufficient for the protective effects of CSE and religiosity for decreasing risk for STIs and unplanned pregnancies. This project's results supported the notion that sex education improves the young adults seeking of sexual health services and lowers STI risk in combination with other variables. Formal sex education programs must effectively teach skills to adolescents that can be retained into adulthood. If these programs are sufficient, we would expect to see high RSE, low STI risk scores, and that young adults would seek sexual health services appropriately. The concept of religiosity has not been previously applied to understanding the young adults seeking of sexual health services. According to the theory of care-seeking behavior, religious beliefs directly influence care-seeking behaviors. Specifically, this project investigated the effects of religiosity on the young adults seeking of sexual health services, which has not been covered in previous research. Since the findings indicate a relationship between the young adults' RSE topics and seeking of sexual health services, it has the potential to influence policy related to sex education standards. As we work to better understand the young adults' motivations to seek sexual health services, we can better tailor interventions aimed to increase the seeking of sexual health services. This includes access to contraceptive services and STI testing. Use of the findings from this project will direct future educational efforts to decrease STI and unplanned pregnancy rates. There must be a general reevaluation and standardization of sex education. These topics should resemble the CDC Essential Topics for Sex Education as was evaluated in this survey. This project indicates a need for earlier initiation of age-appropriate sex education as well as continuation of education throughout adolescence. Future educational interventions must be designed with consideration for cultural influences like religiosity. More highly religious adolescents and young adults should be targeted for future CSE interventions. Education should be approached in such a way as not to encourage risky behavior, but to develop future life skills. These life skills include when and how to seek sexual health services, and discussions about sex and sexual health should be normalized in religious and non-religious communities. This project's findings indicate a relationship between sex education and religion that could greatly benefit or harm young adults. Sex education considering religious values or a lack thereof should still stress the benefits of abstinence, but also include what to expect and how to manage sexual health in the future. Considering the significant findings of this project, but also the limitations, this project should be reworked for future use. It was determined that self-administered social media-based surveys can recruit a large sample size. This project utilized a recall method that highlighted the deficiency of current sex education practices and the overall lack of teaching effectiveness. This survey would have benefited from more selective surveying methods and targeting of at-risk individuals. Again, thank you so much for taking the time to listen to my presentation. If you have any further questions, please feel free to reach out to my email address below. And thank you very much.